Great, thanks Dan. And thanks for the opportunity to present today on our Bedaquiline long-acting clinical development program. So I'll go through some thoughts as to the applicability of Bedaquiline long-acting in the field of TB, whether it be for TB preventive treatment or for active TB disease, and then go into some early insights from our first-in-human phase 1 study of Bedaquiline long-acting. So Bedaquiline is unique as a molecule for being applicable to long-acting. Its CMC properties include a low aqueous solubility, a low plasma clearance, and efficacy at a lower drug exposure with a MIC for Mycobacterium tuberculosis of 0.03 mics per ml. Another strength of Bedaquiline is it is active against strains of both drug-sensitive and drug-resistant TB. This would be particularly important for a TB preventive treatment indication. You would not need to know the source of the infecting strain and could treat all those at risk for development of TB disease with Bedaquiline regardless of the strain. It has a favorable side effect profile. As was mentioned before, Bedaquiline is not a new NCE. It was approved in 2012, and it has a very long safety profile and a lot of large safety databases showing that the drug is quite safe, as evidenced most recently by our full marketing approval by the FDA and the removal of the black box warning for mortality for Bedaquiline. The IM injection then, particularly for TBT, could be that you could administer it once. So we're quite excited to think about the possibility of, say, someone that comes to an HIV clinic, they're newly initiating on ART or perhaps re-presenting to care, and you could say at the same time you're starting your ART, we'll give you this injection and that will protect you against the development of TB disease when you're most susceptible. So shifting to the potential of Bedaquiline long-acting for the treatment of TB disease, we don't have our human PK for Bedaquiline LAAI yet. I'll talk to you a bit about our phase 1 study next. But for now, we're leveraging an oral population PK model. The LAAI bioavailability is assumed at this point to be double the oral administration, but we do know that there's different release rates, both slow and fast, in different animal species. So we have done a fair amount of preclinical work in the rat, dog, and mini pig to look at these different release rates, as well as to assess for the tolerance of a intramuscular injection in some of these species. So we do think that between 4 and 28% of the drug is being released by the fast route, although that is species dependent. What we've been doing then in our early modeling for the LAI dosing for TB disease is to establish a reference PK, and that's based on our current label indication dosage, which is 400 milligrams daily for 2 weeks, and then followed by 200 milligrams 3 times a week for a further 22 weeks, making up a 24-week course. So our target is AUC at 24 weeks in patients with rifampicin-resistant TB disease. What you see in the colors there at the bottom then in green and light blue and dark blue are different assumptions for the dose we would need to administer to treat disease. What it's looking like is that we cannot escape that oral lead-in. So we haven't really gotten to that pie in the sky where you can just give a once-off injection or 1 or 2 injections without the oral lead-in. What was nice, though, in what Kim presented is that there is some provider and patient acceptability to starting with this oral lead-in. And then the other scenarios there, more on the right side, are the number of potential follow-up injections that would be needed after the oral loading. So how does that look then in terms of creating a target regimen profile for bedaquiline and for treatment of RRTB disease? This is hypothetical, but it helps guide us in our assumptions of what a multi-drug regimen could look like that would include bedaquiline. We would certainly like to have it as broadly applicable as possible. So for use in children, people living with HIV, comorbidities, even those with a range of pulmonary disease severity, such as Radha was mentioning earlier. And luckily, bedaquiline does have good cavity penetration and also accumulates in the lymph nodes, albeit a little bit slowly. The number of component drugs, our thoughts are that you would start with an intensive phase where you have more drugs, say 3 or 4 drugs, some maybe oral, some LAI, and that way you really ramp up that bactericidal activity before you would switch to a continuation phase that could include just LAI drugs. It was really interesting yesterday how Kelly described what's been built into the product labels for regimen forgiveness, right? And I think in the field of oral drugs for TB, we were a little bit behind in the advice we gave clinicians on what to do if they missed doses of their oral drugs. So in this case, we've built in a thought process, and hopefully some data will come on what happens if you miss a dose of bedaquiline LAI. What sort of forgiveness would you have before you would need to get them dosed so that it would not have an impact on treatment outcomes? That, of course, is very dependent on the number of injection visits, whether it's 1 or once every 2 months. The dosing frequency then, as I mentioned, for the intensive phase, it would be a hybrid oral LAI regimen, including good cavity penetrating drugs. And the continuation phase would then hopefully be a 2-drug all LAI, so you would have drugs protecting each other, but both the patient and the provider experience would be they wouldn't need to be going to the clinic while those LAIs were on board. And what I've listed in italics there are just a lot of the acceptability drivers that need to go into these assumptions in the TRP. Are patients willing to go to clinic and get 4 injections in 4 different sites? What sort of injection volumes they would tolerate and the frequency they would need them. So to move into our phase 1, and this workshop unfortunately is just coming a little bit too soon for us to be able to present the actual data from the phase 1, which we're working on currently. So the phase 1 study is a traditional single ascending dose study. It's PK safety and tolerability measurements. We're doing ventrogluteal intramuscular administrations of bedaquiline LAI dose or doses, and it's in healthy participants at one site in Europe. So dosing group A was 4 participants. It was our lowest dose, 1 injection, 2.5 mLs or 500 milligrams. Dosing group B is 8 participants and moved up to 1 5 ml injection for a gram dose. And then dosing group C is 2 injections of 5 mLs on both sides for a total of 2 gram dosing, and that was in 20 participants. We're happy to say that we are just recently fully enrolled, so we have everyone that's been dosed in the study, and we have an interim analysis planned after the 3-month point, following up mostly for safety, but some PK sampling of group C. So our interim analysis will be in roughly September of this year. So as with any safety study, we are looking at grade 3 and higher adverse events, and of course serious adverse events as well. We have some adverse events of special interest, including QT prolongation, so lots of ECG measurements, and looking at ALT and AST for any evidence of transaminitis. Those are 2 known side effects from the oral bedaquiline program. Also looking at any hypersensitivity reactions, and then really being very meticulous about monitoring for injection site reactions, all the way from mild to severe. We do have some VAS scales, the visual analog scales, that patients can report on their pain scale from 0 to 100. That's immediately after the injection and then at certain time points thereafter. And then lastly, we have a very simple survey. It's not a patient preference study like what was presented earlier, but is asking the participants before and after they receive the injection, would they rather take a month of pills, so kind of replicating 1 HP, or would they rather take this once-off injection or injections for a preventative treatment indication? We're watching closely how many of them change their mind after the injection. For PK, then, we did do a lot of work and worked closely with Rada and her team and Eric Nuremberger at Hopkins to get a projected preclinical human target exposure for the phase 1. That was set at 0.3 mics per ml based on an oral bedaquiline AUC times 2, and that's to correct for the M2 metabolite of bedaquiline, which acts quite differently in mice versus humans. So it's too soon to estimate the bioavailability, but we know that we are capturing the PK sampling, through our PK sampling, capturing fluctuations well, both within individual and then between everyone in this study. And we're doing, as I said, lots of ECGs, but the dose for this potential preventative treatment is much, much lower than the oral dosing, so we don't think we will see any concerning ECGs. So to summarize then, we're fairly excited about bedaquiline long-acting as one of the first drug to go into first-in-human as a LAAI formulation for TB disease. I personally am quite excited with the prospect of a once-off injection for TPT. I think speaking to some of the comments yesterday, it just would be an additional choice for patients to have as to how they are protected against TB disease. We can certainly shorten duration, both for TPT and for treatment of disease, and I think it has been shown nicely that that's still necessary despite our regimens getting shorter for TB disease. Really happy to see the community engagement and the surveys that have been done so far, because I do think there's a lot of still ongoing work on these acceptability drivers of LAI and TB. And really looking forward to partnerships in our small community of TB. It's more important now more than ever, but we certainly need to have partners for the ability to couple drugs together in LAI formulations. And we're thinking of potential expansion possibly into other infectious diseases. Thanks very much.